Good day, everyone. This is Dr. Von, and for this week, we will be discussing about your toxicology, specifically your drugs of abuse. At the end of this video lecture, the students will be able to learn the basic principles of your pharmacology, then understand the basic terminologies in toxicology, and lastly, we will discuss the different drugs of abuse and its effects. Before proceeding with our toxicology proper discussion, we'll have to discuss first the basic principles of pharmacology. When I check your curriculum, it seems that you do not have any pharmacology course anymore. During our time, during our third year medical technology time, we still have actually pharmacology na topic, but it seems that hindi na siya part ng inyong curriculum. So, I guess it's better to discuss basic principles or concepts about your pharmacology because this will be these concepts or these basic concepts is essential for us to understand better toxicology. With that, this is now the basic principles of your pharmacology, specifically the pharmacodynamics and your pharmacokinetics. When we say pharmacology, it is actually the study of drugs and their effects on a biologic unit. Drugs, which is any substance that brings about a change in biologic functions through its chemical action. So any changes in your biologic function, substance that can cause a change in your biologic function is actually your drugs. Pharmacodynamics is actually actions of a drug on the body, while your pharmacokinetics is the actions of the body on the drug. So let's proceed first with your pharmacodynamics. Again, pharmacodynamics, actions of a drug towards the body. So anong ginagawa ng drugs towards the body? The action of the drugs towards the body. So this basically refers to the receptor interactions, those response phenomena, as well as the mechanisms of therapeutic and toxic action. Doc, ano po yung pharmacokinetics? Your pharmacokinetics, on the other hand, is in the opposite of your pharmacodynamics. It is the actions of the body on the drug. It is basically concerned with ADME. Ito yung tinatawag namin na ADME. This refers to your absorption, distribution, metabolism, and lastly, your elimination. So actions of the body. How does the body absorb the drug? How does the body distribute the drug? How does the body metabolize the drug? How does the body eliminate the drug? So basically, the actions of your body towards the drug. Para hindi tayo malito kung sino si pharmacodynamics and pharmacokinetic kasi nga usually napapagpalit ng mga estudyante kung sino yung drugs on the body or body on the drugs. Pag pharmacodynamics, drug on the body. Tingnan nyo, may letter D. Pharmacodynamics. So, D, drug on the body. Pharmacokinetic, K meaning katawan. Pharmacokinetic, may letter K, which is katawan. So, actions of the body on the drug. So, that's the basic concept ha. Please, wag natin tong pagpapalitin. Pag pharmacokinetics, more of your interaction, dose response, mechanism, therapeutic, and your toxic action. Pag pharmacokinetics, isipin lang yung ADME, which is your absorption, distribution, metabolism, and your elimination. So this is the very nice picture that will differentiate your pharmacokinetics versus your pharmacodynamics. Ano nga yung pharmacokinetics? Kinetics, katawan. Actions of the body towards your drug. While pharmacodynamics, may letter D, drugs on the body. So again, pharmacokinetics, ano yung importanteng concept na dapat nating malaman? It's your ADME. It's your absorption, distribution, circulation, distribution. Lastly, we have your metabolism and your excretion. While your pharmacodynamics is basically the clinical effects or the dose response curve or the drugs at site of action. So ano na yung effect ng drugs towards the body. So later on, we will have a very good diagram that will help us identify these dose response curves. So let's begin first with your pharmacokinetic principles. Let's begin with your absorption. Pag sinabi nating absorption, it is a transfer of the drug from its site of administration to the bloodstream. In short, ita-transfer ang ating drug patungo sa ating bloodstream or patungo sa ating circulation. It is affected by three major factors. Doc, ano po yung mga major factors na yon? Unang-una, the route of your administration. So depending on the type or the route of administration, it will be there will also be an effect on the absorption of the drug. So some route will have greater absorption while other route have poor absorption. So kaya nga it is dependent on the route of administration. Next, blood flow. Blood flow, because increase in blood flow will have a direct relationship to your absorption, meaning increase ang blood flow mo, there will also be increase in your absorption. Lastly, concentration. Concentration referring to your drugs. So pag maraming dose ng drugs ang ating binibigay, of course, mas marami ang maa-absorb ng ating katawan. Mababang concentration will also mean there will be poor absorption of this drug, or lower absorption rather of this drug. So let's proceed with a different route of administration. Number 1, we have your oral route. Your oral route offers a maximum convenience kasi nga, you just have to swallow a pill. This is the most common route of drug of administration. Absorption is slow and less complete. Bakit kaya less complete? Because of the presence of first pass effect. What is this first pass effect, Doc? Your first pass effect is a significant amount of the drug is metabolized in the gut wall. So hindi pa na-absorb ang ating drug. There is already metabolism, or the drug is being metabolized already. That is why there is a slow and less complete absorption because of this first pass effect. What else? Because this could lead to your drugs may undergo portal circulation, meaning it will go to the liver and undergo also metabolism. Because remember, majority of your metabolism happens in your liver or in your portal circulation. Next, we have also your intravenous route. Your intravenous route, instantaneous and complete absorption. Again, there is a word, complete absorption, that bypasses first pass effect. Therefore, there is 100% bioavailability. In short, walang nangyayaring first pass effect kasi nga it is direct to our blood vessel, direct sa ating blood circulation. It is more potentially dangerous. High blood levels reach on a rapid administration kasi nga directly nating tinutusok sa blood vessel, therefore mas mabilis or direct na pumapasok sa ating blood circulation. That is why one of its also side effects is that it is difficult to reverse the effects. Number 3, we have also your intramuscular route. So your intramuscular route, absorption is faster and more complete than oral, higher bioavailability, and also it bypasses the first pass effect. Number 4, we have also your subcutaneous route. It is slower absorption than your intramuscular route. However, no blood vessels, because of no blood vessels in your subcutaneous space compared to your intramuscular route. Large volume doses are less feasible. It also bypasses your first pass effect. Anticoagulants do not cause hematomas when administered via this route because there is no presence of your blood vessels. Next, we have also your buccal or your sublingual route. So your buccal pouch between the gums and the cheeks. Sublingual, under the tongue. It's a direct absorption into the systemic venous circulation, bypassing again the first pass effect. That is why when we have patients na hypertensive, we give our patient your captopril, which is a anti-hypertensive drug. Tapos, we ask the patient to put it sublingually or nasa ilalim ng ating mga dila. Kasi nga, yung under the tongue is highly vascularized, specifically your venous circulation. Masyadong maraming veins na nasa ilalim ng ating dila. Therefore, it will be directly absorbed inside our systemic venous circulation. Hindi na siya dumadaan ng first pass effect. Next, we have also your rectal suppository route, which is a partial avoidance of your first pass effect. Useful for large amounts of drugs with unpleasant taste and for patients who are vomiting. Ano yung bakit doc partial avoidance lamang siya ng first pass effect? Why not a complete avoidance? Bakit partial avoidance? Kasi nga, remember the venous drainage of our rectum? Remember the venous drainage of rectum, we have three. We have your superior rectal vein. Excuse me. We have your middle rectal vein. And lastly, we have your inferior rectal vein. Your middle and inferior rectal vein will go directly to the systemic circulation. However, your superior rectal vein will go first to your portal vein. Therefore, there will be a partial first pass effect. So, mayroon pa ring nag-undergo ng first pass effect. That's why only partial avoidance because of your superior rectal vein. Next, we have also your inhalational route. It offers delivery closest to the target in respiratory diseases. There will be a rapid absorption with minimal systemic effects. This is actually convenient for drugs that are gases at room temperature or easily volatilized. Next, we have also your topical route. Your topical route is basically the application to skin, mucous membranes of the eye, ear, nose, throat, airway, or vagina for certain local effect. Again, topical route is just only for local effect. Absorption varies in the area of application and drug formulation. So, depending on the area of application, whether there is more blood vessel in that certain area or mas maraming or mas konting blood vessel. So, depending on the area of application. This is actually the slowest route of your drug administration. And lastly, we have your transdermal route. Your transdermal route is the application to the skin for systemic effect. Absorption occurs very slowly but bypasses again your first pass effect. Okay, we're done with the first pharmacokinetic principle, which is your absorption. Now, let's proceed with your distribution. Your distribution is actually the process wherein the drug reversibly leaves the bloodstream and enters now to your target organ. So, after siyang ma-absorb ng ating katawan sa ating circulation, it will now leave the bloodstream and go to its target organ. It is dependent on four major factors. So, what are those four major factors? Number one, the size of the organ. So, the size of the organ is directly proportional to its distribution, meaning the larger the organ or the more compact the organ is, the more extensive the distribution will be. How about your blood flow? Same, your blood flow. Blood flow is also directly proportional to its distribution, meaning the more blood flow, the more extensive ang ating distribution ng ating drugs. How about solubility? For solubility, non-ionized or non-polar drugs which are more lipid soluble, it undergo more extensive distribution, meaning the more soluble or lipid soluble ang ating ang ating drugs, the more na undergo an extensive distribution. How about protein binding? For protein binding, the more our drugs is being bind to your protein, therefore, it has lesser distribution. Again, protein binding is actually inversely proportional to your distribution. Bakit? The more na nakabound siya sa ating protein, the more na hindi siya madidistribute sa ating katawan. So let's repeat again. The size of the organ, it's actually directly proportional, meaning mas malaki, mas compact, mas extensive ang distribution. How about blood flow? The more na maganda ang ating blood flow, it's also directly proportional with our distribution, meaning more extensive also ang kanyang distribution. Solubility, the more na lipid soluble ito, the more na extensive ang distribution, meaning it's also directly proportional. How about protein binding? Si protein binding, the more na nakabind siya sa ating protein, the lesser the distribution will be. So si protein binding lang ang inversely proportional. Pero si solubility, dapat lipid soluble, not water soluble. How about metabolism? So we're done with absorption, then we're done with your distribution. Now the metabolism. Doc, ano po ba yung metabolism? So your metabolism, drugs are chemically altered in your body. So drugs may undergo 3 metabolic fates. So ito yung mangyayari sa ating drugs after niyang magawa yung certain action niya. There will be termination of drug action. Drugs are metabolized into biologically inactive derivatives. Conversion to a metabolite is a form of, elimination. So therefore, pag nagawa na ang kanyang specific action ni drug, then there will already be termination of drug action via your metabolism. Drug activation, prodrugs are metabolized in the body to become active. Or pwede ding once na metabolize ang drug, saka pa siya nagiging active. So prodrugs are metabolized in the body to become active. Some drugs are metabolically active but still have active metabolites. And lastly, elimination without metabolism. Some drugs are not modified by the body and continue to act until they are excreted. So in short, they are not needed to be modified, but they can still continue to do its action until they are fully excreted. So these are the fates of your drugs. Pwede siyang ma-terminate, termination of your drug action. Pwedeng ma-activate ang drugs. And lastly, elimination without metabolism. So this is your metabolism. So your metabolism has 2 important phases. Meron tayong phase 1 and meron tayong phase 2. Doc, ano po yung phase 1? Your phase 1, the goal sa ating phase 1 is actually to convert the drugs to be water-soluble. Yet, some drugs are still active. Bakit ba natin kino-convert ang drugs into water-soluble? Kasi nga, we want to eliminate this easily by the body. Kasi pag hindi ito water-soluble, then it will not be eliminated by the body. How about phase 2, Doc? Your phase 2, the goal is actually to make the drug more water-soluble and inactive. So, to completely make the drug more water-soluble and inactivate the drug itself. Again, ano yung dalawang phases ng metabolism? Phase 1 and phase 2. Phase 1, to make it water-soluble. But some drugs are still active. Phase 2, ang goal sa phase 2 is to make the drug more water-soluble and inactivate the drug para easily na ma-eliminate. So that's your metabolism. So your metabolism mainly happens in your liver and some in your kidneys. Lastly, we have your elimination. Your elimination is the termination of your drug action. So you're already terminating the action of the drug. So it is actually excretion. So elimination is actually synonymous to excretion. Release of the drugs or their metabolites in your urine, stool, bile, exhaled air, etc. Duration of drug action is actually determined by your dose administered and the rate of elimination following the last dose. Meaning, kung mas maraming ang dose ng ating na-administer drugs, of course, mas matagal itong na-eliminate kasi nga kailangan mas maraming oras para ma-metabolize ito and easier for it to be eliminated. And also the rate of elimination. So, sobrang mabilis ba or sobrang mabagal ang pag-eliminate ng certain drug? So again, let's repeat about pharmacokinetic principle. Pharmacokinetic, may letter K, katawan to the drugs. The action of your body towards the drug. Ano nga yung apat na principle na dapat natin malaman sa pharmacokinetic? It is your admin. Number one, we have your absorption. And there will be certain different routes. Next, we have your distribution. So there's also different factors that affects distribution. Lastly, metabolism. Metabolism is basically transforming this drug into water-soluble so that it can be easily eliminated, which is the last principle of your pharmacokinetic, which is your elimination. That's your admin. Now let's proceed with your we still need to determine the different types of eliminating the drug. So we have your first order elimination and your zero order elimination, saturable, or your Michaelis-Menten kinetics. Ano yung first order elimination, Doc? Your first order elimination is actually the rate of elimination is proportionate to the concentration. So the concentration decreases exponentially over the time. So the characteristic half-life of elimination. So the concentration decreases by 50% for every half-life. Most common type of elimination is your first-order elimination. So dito na yon na-apply natin yung half-life ng certain drug. So ano ibig sabihin yan? So half-life, for example, half-life ng drug X is actually every 3 hours. So meaning to say that, for example, you give 50 milligrams. So the half-life is actually every 3 hours. So after 3 hours, the drug dosage will become, since the half-life niya is every 3 hours, from 50 milligram, nagiging 25 milligram na lamang. Then after 3 hours again, that 25 milligram, nangangalahati, nagiging 12.5 until such time na mas lalong lumiliit ang kanyang value. So that's your first order. This is actually the characteristics of your half-life elimination, which is the common type of elimination. Next, we have your zero-order elimination or your saturable or your Michaelis-Menten kinetics. This is the rate of elimination is constant regardless of your concentration. Concentration decreases linearly over your time. Occurs when drugs have saturated their elimination mechanism. So, anong ibig sabihin nito, Doc? So, it decreases over time. Meaning, for example, meron lang certain constant ang kanyang elimination. For example, 50 milligram drug. So, may eliminate siya every 3 hours. 10 milligram lang ang ma-eliminate niya every 3 hours. So, for example, 50 milligram after 3 hours, sasubtract natin ng 10 mg kasi constant na na-eliminate niya is only 10 mg. So after 3 hours, nagiging 14 na lamang yung 50 mg. Then after 3 hours, nagiging 30. After 3 hours, nagiging 20. After 3 hours, nagiging 10. So meaning, there is constant elimination. Unlike your first order, it is based on the half-life of your certain drug. So, tingnan natin sa diagram para mas lalo nating maintindihan. So this is how we differentiate your first order elimination versus your zero order elimination. For your first order elimination, there is a based on the half-life of the certain drugs. For example, ito, every hour half-life niya, every hour ang kanyang half-life. For example, we give 5 units of that drug. So after 1 hour, nagiging 2.5 because half-life niya. So 5 divided by 2, nagiging 2.5 after an hour. Next, after an hour, i-divide mo na naman ng 2.5, nagiging 1.25. So first order is basically based on the half-life of the drugs. while your zero order elimination from 2.5 units, babawasan lang natin ng certain amount ng drugs. So for example, this drug here, for example, ito is 10 milligram, babawasan ng 2.5. Another, so nagiging 7.5 na lang dito. Tapos babawasan mo rin again ng 2.5 units, nagiging 5 na lamang. Tapos dito, babawasan mo ulit ng 2.5, nagiging 2.5 na lamang. So in short, there is just a constant amount, so depending on the concentration. So first effect, based on the half-life, zero order elimination, there will be based on a constant amount of drug. Kaya nga tinatawag natin zero order, guys, kasi nga it will reach a 0 point. Tingnan nyo, magiging 0 yan. For example, 10 magiging, subtract mo ng 2.5, nagiging 7.5. Subtract mo ng 7.5 minus 2.5, nagiging 5. Then 5 minus 2.5, nagiging 2.5. Tapos 2.5 minus 2.5, nagiging 0. So it will reach the what is this? The y-axis. So it will basically, this is the or x-axis. No, this is the x-axis. So it will reach your x-axis, nagiging 0. Kaya nga, zero order elimination. However, your first order elimination, kahit anong divide mo yan ng 2, ng 2, ng 2, it will never reach the 0 value. Kumukonti ang value, but it will never reach the 0 value. So that's how you differentiate your first order elimination and your zero order elimination. Now, let's proceed with your pharmacodynamic principle. Sa pharmacodynamic principle, ano nga to? Pharmacodynamic, may letter D, drugs. Effect of the drugs towards the body. Drugs to the body. So, I want you to remember this quantal dose response curve. This quantal dose response curve, this is the minimum dose required to produce a specified response, is determined in each member of a population. Your quantal dose response curve, fraction of the population that responds at each dose against the logarithm of the dose administered. Meaning, this is where your median effective dose, median toxic dose, and median lethal dose are being derived. So dito na di-derive yung mga effective dose, toxic dose, and your lethal dose based sa quantal dose response curve. So, tingnan natin to. So, dito is actually, sa ating x-axis, this is actually your drug dose. This one, your y-axis, this is actually your response dose, or the effect of a certain drug if able to reach a certain therapeutic range or percentage. At this level, if you give a certain drugs at this level, or certain dose of the drug at this level, you will be able to reach the therapeutic effect dito at certain level. Sabihin natin, for example, at 10 milligram, we reach this level, there will be a therapeutic effect. When we add more milligram or dose to our drug, for example, sabihin natin, nagdagdag tayo ng additional drug, nagiging 20, nag-add tayo ng additional 10, nagiging 20. Nagiging 20, at this point, nagkakaroon na tayo ng toxic effect. Your toxic effect. And lastly, when we add another milligram or dose to our drug, nagkakaroon tayo ng lethal dose. So in short, habang pinaparami natin yung dose na binibigay sa ating patient, maaaring magkaroon tayo ng therapeutic effect, toxic effect, or lethal dose, because certain drugs will have its own therapeutic effect at a certain milligram or dose. But when we are already exceeded the therapeutic effect, then we might reach its toxic effect, where we could reach a lot of different side effect or toxic effect of the body. While when we give more than that of your toxic effect, we may be able to reach the lethal dose of a certain drug. So let's define this ED50, PD50, and LD50. Tingnan natin dito. Pag sinabi nating median effective dose, it's actually the dose at which 50% of the individual exhibit a specific quantal effect. So, it refers to the 50% of the individual, while your median toxic dose is actually the dose required to produce a defined toxic effect in 50% of the subject, while your median lethal dose, this one, is actually the dose required to kill 50% of your subject. So lethal dose, this is already a to kill or deleterious effect to the human body. So therapeutic median effective dose, 50% that have a specific quantal effect. Median toxic dose, required to produce a toxic effect in 50% of your population. Your lethal dose is required to kill 50% of your subject. So that's how you differentiate your therapeutic effect, your toxic effect, and your lethal effect. So depending on the drugs, merong certain milligram ng certain drug na therapeutic sa kanya. Pag sumobra, nagiging toxic. Pag lalong sumobra, nagiging lethal effect. Meron din tayong tinatawag na therapeutic index. Your therapeutic index is actually the ratio of your this is your therapeutic drug to your toxic drug, rather, to your effective dose. Your therapeutic dose, your toxic dose rather, to your effective dose. This is a parameter which reflects the selectivity of a drug to elicit a desired effect rather than toxicity. Again, your therapeutic dose or therapeutic index is the ratio of your toxic dose to your effective dose. Now let's talk about your efficacy versus your potency. Your efficacy or your efficacy is actually the maximal efficacy or Emax. Maximal effect an agonist can produce if dose is taken to very high levels, so determined mainly by the nature of the receptor in its associated effector system. So meaning, you give a certain dose that can reach the maximum efficacy. For example, you give 50 milligram, but this 50 milligram is not the maximum dose. So baka dito lang siya. So that's not the Emax or the efficacy, but rather when we say efficacy, this refers to your maximum effect or your Emax. For example, A, you give 100 milligram and that is your maximum efficacy. How about your potency? Your potency denotes the amount of drugs needed to produce a given effect. It is determined mainly by the affinity of your receptor for the drug. Denotes the amount of drug needed to produce a given effect. So meaning, for potency, meaning certain amount of drug that can already produce a certain effect. So if we compare this one, for example, A, B, and C. At a certain dose, for example, ang dose ng letter A is actually, so this is drug A, this is drug B, this is drug C. Si drug A is only 10 milligram, but at 10 milligram, you already reach a maximal efficacy. Si drug B, at 20 milligram, dyan ka pa nakaka-reach ng maximal efficacy. Si drug C naman, at 30 milligram, dyan ka pa nakaka-reach ng maximal efficacy. Again, for example, si drug A, B, and C. Si drug A is 10 milligram. Si drug B is 20 milligram. Si drug C is 30 milligram. Pareha silang drug, kaya lang si 10 milligram na drug A, si 20 milligram na drug B, at si 30 milligram na drug C, dyan pa sila nakakakuha ng maximum efficacy or your Emax. So that's your efficacy. Doc, how about your potency? Your potency is actually the amount of drug needed to produce a given effect. If we are looking for a maximum effects, sino ang pinaka-potent sa kanila? Si A, si B, or si C? What's your answer? mas potent si letter A kasi nga it denotes the amount of drug needed to produce a given effect. So, at what dose this drug will be able to produce certain effect. Si drug A, tingnan nyo, 10 mg lang, pero nakaka-maximum efficacy na siya. Samantalang si drug B, kailangan niya pa ng 20 mg para magkaroon ng maximal efficacy. Unlike letter C, si letter C kailangan pa ng 30 mg para magkaroon ng maximal efficacy. Therefore, pinaka-potent si letter A kasi nga bababang amount lang ang kanyang kailangan para ma-reach ang maximum effect unlike sa B and sa C. So sa A, B, and C, sino ang pinaka-potent? It's your letter A. Si B and C, sino ang pinaka-potent sa kanila? It's your letter B. While your letter C is the less potent because it needs more dose of the drug for it to produce a given effect. In short, si potency, kung sino ang pinakamababang dose na magkakaroon ng effect, then that will be the most potent drug. Again, pag sinabi nating potency, kung sino yung pinakamababang concentration ng drug na makakapag-produce ng certain effect, then that will be your most potent drug. So we're done with our basic principle. It's very short lang talaga, guys. At least you have an overview of what are the basic concepts na dapat nyong malaman in terms of your pharmacology. So just remember your pharmacokinetics and your pharmacodynamics. Now let's proceed with our lecture proper, which is your toxicology or your drugs of abuse. So for the definition of terms, pag sinabi nating toxicology, it is actually the study of the adverse effects of xenobiotics in human. Pag sinabing adverse effects, this is actually any change from an organism's normal state. So any abnormal that is happening to you, then upon the concentration of an active compound at a target site for a sufficient time, then that's going to be your adverse effect. Ano po yung xenobiotics, Doc? Your xenobiotics, these are chemicals and drugs that are not normally found in or produced by the body. So that's your toxicology. Adverse effects of your chemicals or drugs in your body. So let's define xenobiotic versus poison versus toxin. So these three terms are often used interchangeably. However, there are some important distinctions. Again, pag sinabi nga nating xenobiotics, this refers to your chemicals or drugs. Describe the environmental exposure to your chemicals or drugs. So this example for these are your antibiotics, antidepressants, or even your chemical exposures. How about your poisons? Your poisons, more often used when describing substances from an animal, plant, mineral, and including your gas. So example are your, venoms from your poisonous snakes or spiders, poison hemlock, your arsenic, your lead, and your carbon monoxide, your gases. And lastly, we have your toxins. So your toxins are your endogenous substances. So unlike your xenobiotics and your poisons, these are your exogenous, meaning sa labas. But your toxins refers to your endogenous substances biologically synthesized either in living cells or in your microorganisms. So example nito, we have your Botox, which is basically produced from your Clostridium botulinum, your hematoxins produced from your venomous snakes, and your mycotoxins produced by your fungus. So substance abuse, what is substance abuse? This is repeated non-therapeutic use of any drug in doses or schedules which produce a significant risk of adverse effects to the user or others. So meaning to say, if there is no or non-therapeutic usage of a certain drugs that produces a significant adverse effect to the user or to the others, that's actually refers to your substance abuse. What is acute toxicity, Doc? Your acute toxicity is usually associated with single short-term exposure. This is the important clue. Short-term exposure to a substance in which the dose is sufficient to cause an immediate toxic effects. How about chronic toxicity? It is generally associated with repeated and frequent exposure for extended periods of time, months to years, at doses that are insufficient to cause an immediate acute responses. So these are the prevalence of your common drugs of abuse. So based on this diagram, this actually comes from your bishop. So alcohol is the most prevalent drugs of abuse, followed by your marijuana, your cocaine, your mga benzodiazepines, your barbiturates, question mark, and some of other drugs. So we will be discussing these drugs isa-isa. So let's proceed with your opiates. So first drug of abuse will be your opiates. So opiates, nabilong dyan yung morphine, your codeine, your heroin, your fentanyl, your naloxone, your methadone, and your propoxyphene. Actually, your naloxone is not an opiate, but it's an opiate antagonist. So later on, we will discuss about your naloxone. So your opiates is actually subdivided into 3 groups. Meron tayong sinasabing full agonist, meron tayong partial agonist, and lastly, we have a weak agonist. So among these opiates, sino dito ang full agonist? Ang full agonist dito, nandito si morphine, si heroin, si fentanyl, at saka si methadone. Again, ang full agonist natin dito, we have your morphine, your heroin, your fentanyl, and your methadone. That's your full agonist. So, ano po yung full agonist? Yung full agonist has high efficacy, producing a full response while occupying a relatively low proportion of receptors. Meaning, it has very high efficacy. Makakapag-produce siya ng kanyang full effect or full response. Meron naman tayong sinasabing partial agonist. Among this group, sinong partial agonist dito? It is actually your codeine. Your codeine is a partial agonist which has lower efficacy than a full agonist. And lastly, we have a weak agonist. Ang pinaka-weak agonist dito is your propoxyphene. Your propoxyphene is a weak agonist, meaning mas mababang effect kesa sa ating partial agonist. So let's begin your morphine. Your morphine is actually the metabolite of your heroin. So your heroin is metabolized to morphine. It is actually the synthetic opiate from your morphine. So yung heroin natin ay actually nagmula sa ating morphine. So dyan, nagmula ang ating heroin from a synthetic opiate. So the main functions of your opiates is actually a pain reliever by binding to your mu receptors in your CNS, which inhibits the effect of your GABA on a dopaminergic neuron. So anong ibig sabihin nito, Doc? Inhibits the effect of GABA. Ano ba ang GABA receptor? I guess you already discussed this when you had your adrenal discussion, yung mga different neurotransmitter. So I guess you were already familiar with this. Pag sinabi natin GABA, di ba ang GABA is inhibitory in nature. Pag inhibitory in nature, tingnan natin, inhibits the effect of your GABA. Meaning, ini-inhibit niya ang inhibitory effect ng GABA. So therefore, wala nang mag-i-inhibit sa ating dopaminergic neurons kasi nga, ini-X mo na or ini-inhibit mo ang GABA. Anong function ni GABA? Inhibitory. So in short, there will be continuous stimulation of your dopaminergic neurons. If there will be continuous stimulation of your dopaminergic neurons, therefore, there will be a euphoric effect. Ito yung gusto natin, yung euphoric effect. That's why it's drugs of abuse. Next, your heroin. Your heroin induces a pleasant euphoric state. The same again, because they are of the same group, your opiates. The form of your heroin is actually a diacetyl form of your morphine, and it can cross your blood-brain barrier. Your half-life of your heroin is approximately 3 hours, and it's N-acetylmorphine, and again, and morphine as your metabolites. Kasi nga, your heroin comes from the synthetic forms of your opiates, which is your morphine. Heroin, it has a paradoxical effects on the parasympathetic nervous system, or it's a procholinergic. So I guess you discussed this with your adrenal part, remember your parasympathetic, which is basically the opposite of your sympathetic, diba? Yung sympathetic is the fight or flight response, right? So opposite of that is your parasympathetic. So this is, remember, parasympathetic uses your cholinergic effects. So that's why it has the effects on your eyes, on your blood vessels, causing pinpoint pupils and your peripheral vasodilation. That's why your heroin has a parasympathetic response. Pag meron tayong heroin overdose, these are the common manifestation. Actually, different drugs will have these drugs, including your morphine, your codeine, your fentanyl, will have these kind of overdose symptoms. There could be severe obtundation or mababa ang consciousness ng ating pasyente. There will be coma, respiratory arrest, hypotension, and your cardiac arrhythmias or improper beating of your heart. These are the withdrawal symptoms or the myriad symptoms when you are not already taking heroin. So for those patients na who are constantly consuming heroin then suddenly stops, then there will be possible withdrawal effect. Meron tayong tinatawag na hypothermia, palpitation, cold sweats, nightmare. So that's why the withdrawal symptoms is basically the opposite of your parasympathetic stimulation. Remember, itong opiates is a parasympathetic ang kanyang side effects. Kaya nga, pag tinanggal mo ko yung opiates, then the opposite, the withdrawal symptoms will be basically the opposite lamang ng ating parasympathetic. This is gonna be your sympathetic. So, kaya nga, may palpitation. So I guess this makes sense. Next, we have also your codeine. Your codeine, it's given, actually this is commonly used for your mga cough suppression, or this is actually used as antitussive. So given in 50 to 30 milligrams in 3 to 4 times per daily. But when you reach around mga 100 to 200 milligram, that's already can cause light intoxication. But when you reach around 1,500 milligram, then there will be heavy intoxication. Then the patient will have a manifestation of lethargy or parang nagiging sluggish ang pasyente. There will be hyperexcitability of your different reflexes. There will be nystagmus or involuntary eye movement. Then ataxia, lack of your muscle coordination, nawawala sa balanse ang pasyente. There is improper movement. Then slurred speech, lastly tremors, and your hyperreflexia or your hyperexcitability. So again, what is the function of your codeine? So opiates in general are analgesic. It's also, your codeine is antitussive of your cough suppressant. So usually this is the analog drug of your codeine, your dextromethorphan. So I guess right now there is already a regulation when you buy certain drugs such as your Robitussin. I'm not sure if this is still legal in the Philippines, but there are certain countries that already ban the use of this Robitussin because of its potential effect of addiction. Kasi nga, may mga times talaga na ibang pasyente, they will just buy Robitussin or mga dextromethorphan containing analogs para lang just to suffice their addiction. So I'm not sure if this is still available in the country, but when I asked my friend who is a pharmacist, is also a physician, if available pa ba tong dextromethorphan, I chatted her kanina, and she told me na it's not already available in the Philippines, or maybe it is still available but regulated. Hindi ka basta-basta makakabili nito because of its potential effect of addiction. We have also your fentanyl, which is 80 times more potent than morphine. Ano nga ang ibig sabihin ng potency? At a low dose, you can already have that maximum effect or your effect na ating hinahanap. So 80 times more potent sa ating morphine. It is also taken as orally as fentanyl lollipops. Ito yung na-search ko sa internet, your fentanyl lollipops. Di pa ako nakakita nito. Usually, ginagamit lang namin to yung fentanyl as an analgesia during surgery. So, usually, nagbibigay nito is your mga anesthesia doctors. So, sila yung fentanyl ang ginagamit namin. Then, you can use this as smoke or inhaled or as a transdermal fentanyl patches. We have also your methadone. Again, your methadone, which is a full agonist. It binds competitively with your morphine. It is also addictive effects are less compared to your heroin. Lastly, we have your naloxone. So your naloxone or your brand name Narcan, excuse me, it's actually a competitive antagonist. So this is not actually part of the opiates, but this is a opiate antagonist. Pag meron tayong pasyenteng nagkakaroon ng morphine overdose or opiate overdose, ang binibigay namin sa pasyente is your naloxone. So your naloxone is the one that will it's an competitive antagonist for your opiates. So binibigay namin ang naloxone. So meron kaming tinatawag na triads for your opioid poisoning. Ito yung check namin if we are suspecting for a possible morphine overdose, heroin overdose, codeine overdose, opiate overdose. These are the three important triads that you have to remember. For opiate triads or for your morphine triads, there will be pinpoint pupils, respiratory depression, and decreased level of consciousness or coma. That is why when we do morphine rounds, we do morphine rounds pag nasa anesthesia rotation kami, naggagawa kami ng morphine round. So, yung after we do surgery for our patient, nagbibigay kami ng morphine to provide analgesia para less the pain ang aming pasyente. Kasi nga, for those mga undergo na mga extensive surgery, of course, that's gonna be very painful after surgery, right? So, we need to continuously give morphine. So, when we do morphine rounds our patient, we always check first the BP of our patient. Check namin kung nagiging hypotensive ba ang pasyente namin. Kasi nga, this is also a sign that the patient might have a morphine overdose na binibigay namin. Next, check namin if yung kinakount namin yung respiratory rate ng patient. So after mga for example 10 to 15 minutes, we check again the respiratory rate of our patient if there is no respiratory depression. That's why it's really important for us to monitor our patient para makita namin kung walang nagkakaroon ng morphine overdose. Next, we have your tranquilizers, basically your diazepam and your oxazepam. Actually, these are your sedative drugs. Marami pa to, guys. It's not only your diazepam, we have your mga midazolam and different others, mga benzodiazepines. So your benzodiazepams or your mga tranquilizers or your Valium, potentiation of GABA, a neurotransmitter that inhibits conduction in your dopaminergic neurons. So in short, you will potentiate your inhibitory transmitter that will inhibits the conduction of your dopaminergic neurons, therefore causing a calming effects. The therapeutic drug to produce a calming effects of your benzodiazepines is at dose of 2.5 and 10 mg. Actually, this is depende siya sa type ng drug na binibigay namin. For example, mga midazolam, that's only short-acting. So every minute we can give or every after 10 minutes. So depending on the drug. So your benzodiazepines here are actually commonly prescribed medication for anxiety, sedation, and sleep. Your in terms of toxicity with your benzodiazepine, for example, meron tayong benzodiazepine toxicity. Some patients tend to increase, for example, meron silang mga sleep problem. Some patients tend to take a lot of benzodiazepines. So, nagkakaroon sila ng benzodiazepine overdose. So, tinitingnan naman namin dito is there is impaired mental status, drowsiness, slurred speech, ataxia, coma, or even respiratory depression. So that's give us an idea that patient has your benzodiazepine overdose. Ang binibigay namin na antagonist or antidote for benzodiazepine overdose, it's your flumazenil. Your flumazenil is a benzodiazepine antagonist. Again, ano nga yun sa morphine overdose? Anong binibigay natin na antidote for your morphine overdose? It's your naloxone. While for benzodiazepines overdose, anong binibigay natin? It's your flumazenil. Next, we have your barbiturates. So different barbiturates, nandito, we have your mga phenobarbital, which is the long-acting type. We have amobarbital, immediate-acting, pentobarbital, which is short-acting, and we have also your thiophental, which is the ultra-short-acting. So in less than a minute, it could already have its own effect. So your barbiturates, this is a sedative or hypnotic drugs. Most commonly, we have your phenobarbital, which is actually a long-acting. So since this is a long-acting, this is used as a anticonvulsant. So this is drugs that we give to our patient who have mga epilepsy or mga epileptic disorder. So binibigay namin is your phenobarbital. Pero for example, if the patient has mga acute stages lamang ng seizure, so ang binibigay namin is yung mga midazolam lamang or mga benzodiazepines since it's already a short-acting. But if, for example, mga epilepsy disorder which is already a long-term problem, so ang binibigay namin is your phenobarbital which is a long-acting barbiturates. So we have also your dopaminergic pathway stimulants. So these are the different dopaminergic pathway stimulants. We have your cocaine, we have your benzoyl agonine, which is the less active metabolite. We have your mga amphetamine derivatives, we have your methamphetamine, and your methylphenidate. And also, meron din tayong tinatawag, you're familiar with this, your designer amphetamines or your designer drugs. Most importantly, your ecstasy or your MDMA or ecstasy or your 3,4-dimethyl enoxymethylamphetamine. First, let's discuss your cocaine. So your cocaine from your coca plant, which is a derivative of your alkaloid ecgonine. The normal route is actually through inhalation or snorting. So this is usually done as cracked or smoke from a pre-base form that passes rapidly across your nasal membranes. The half-life is only around 1 to 2 hours. That's why it can be cleared within 2 days. So your cocaine has a local anesthetic effect. So minimal effect lang naman siya. It can induce local anesthesia during your nasopharyngeal surgery. However, this is not already used because cocaine is an illicit drug. It can induce euphoria state and your hallucinatory state. So what is the mechanism of action of your cocaine? Basically, it increases your calcium ion influx. Pag mataas ang calcium influx, it will cause the activation of your phospholipase. Therefore, it will induce your dopamine. Kaya nga, dopamine stimulatory drugs. Pag maraming dopamine, it will cause now your euphoria state and your hallucinatory states. That's why this is one of common cause of your common drugs na ginagamit natin for drugs of abuse ng mga drug addict. So, some abusers consume together with alcohol. So, gumagamit din sila ng alcohol while they are taking your cocaine because they found out that your ethanol becomes esterified to cocaine inside your liver to form your coca-ethylene. Your coca-ethylene will block the dopamine reuptake. Pag hindi reuptake ang dopamine, meaning mas maproprolong ang kanyang effect. So there will be more stimulation of your dopamine neurons. So in short, mas lalong nagkakaroon ng euphoria effect. So it can cause your placenta. That's why it can cause severe mental retardation, delayed development, and malformations in your utero. That's why when we deliver patients na mayroong mga malformation and other, we try to elicit the history of the patient if there is a history of illicit drug use other than taking of other drugs. Kasi nga, it's very important. Like your cocaine can really cause severe malformation, mental retardation, and delayed development even inside your uterus. Now, let's proceed with your amphetamines. Your amphetamines are what we commonly term as your shabu. It's bear a close resemblance to your catecholamines. Ano nga yung mga catecholamines when you have your adrenal discussion? It's your mga norepinephrine and your epinephrine, your fight and flight response. That's why it has a sympathomimetic effect. So it resemble your dopamine. Saan ba nanggaling ang ating norepinephrine and your epinephrine? Diba nanggaling sila sa ating dopamine. That's why it resemble your dopamine. It also acts as a competitive inhibitor of your monoamine oxidase. So, ano bang trabaho ng monoamine oxidase? Tingnan natin dito. So, your monoamine oxidase, here, your monoamine oxidase will actually metabolize your norepinephrine. Kaya para magiging inactive ang ating norepinephrine. So, that's the action of your monoamine oxidase. When certain person had an intake of your amphetamine, what will be the effect? There will be resemblance of your dopamine. There will be more increased level of your norepinephrine. But your amphetamine can also cause a competitive inhibition of your MAO. So it could act as a MAO inhibitors or your monoamine oxidase inhibitor. When it acts as a MAO inhibitor, it will inhibit your MAO. Therefore, walang mag-metabolize ng ating norepinephrine. Therefore, there will be still increased level of your norepinephrine causing a sympathomimetic effect. That's why your amphetamine is highly a stimulatory or psychostimulant kasi nga it will continuously increase the level of your norepinephrine. Talagang high na high ka dito. Kasi nga, wala nang mag-i-inhibit sa levels ng iyong norepinephrine. Dumadami pa ang norepinephrine nyo kasi nga nagre-resemble siya as dopamine at nagiging competitive inhibitor pa siya ng ating MAO or your monoamine oxidase. Therefore, decreasing the metabolism of your norepinephrine, thereby increasing more the level of your norepinephrine. So we have this important synthetic part of your amphetamines. We have your ecstasy or your MDMA, which is your 3,4-methyl and methylene methamphetamine. Again, we have your 3,4-methylene methamphetamine, which is your MDA or your ecstasy. Nabubulol. So your MDMA or your ecstasy this is very common used as your recreational drug of abuse. It can cause also your euphoric and your psychedelic effect with minimal hallucinogenic effects. Right now, very rampant ito during mga different concerts kasi nga parang if you just check it, may mga binibigay lang na mga ganito and you check para lang siyang chewable tabs, para lang candy, but lo and behold, it's actually already a recreational drugs. And these people tends to have more energy. They have this kind of euphoria, parang mga psychedelic effect. Hindi sila napapagod. That's why this is very, very delikado. Kasi nga, if you have certain conditions, then you might have problems with that. Now let's proceed with your hallucinogens. This is actually second to the last topic, I guess. We have your phenylcyclidine, we have your methaqualone, we have your LSD, and your cannabinoids. So your phenylcyclidine, I'm not familiar with this one, but this is your angel dust or your angel hair. It has also a analgesic and anesthetic effect, and it is actually stimulatory also. It can interact with your cholinergic, adrenergic, gamma-secreting, serotonergic, and opiate neuronal tissue. Ang dami niyang mga receptors na pwedeng maka-apekto. That's why it is very stimulatory. We have also your propocyphene, which is a analgesic drugs. Very similar in action with your opiates, causing a sedative effect. Now we have your methaqualone, same sedative hypnotic properties as the barbiturates. It is also acts as your anticonvulsant, antispasmodic, local anesthetic, antitussive, and your weak antihistamine action. So these are not common here in our country. We have this one. This is very common. Your lysergic acid diethylamide. This is very common hallucinogen, which can cause blurred or undulating vision. So panic reaction as your adverse reaction. So usually when we ask patient kung kung meron kami mga toxic na patient, if we are thinking na baka ito ay nagda-drug abuse, and we try to ask the patient na, ma'am, ano yung iniinom niyo na drug? Then some patients doesn't know the name of the drugs, but when they try to describe the drugs or the pill na ginagamit nila, they will just say na the color pink po ito kasi usually your LSD is actually a pink pill. Pero right now, there's already a lot of variants of your LSD and your ecstasy. They tried to, parang nag-a-adapt na rin sila. Binabago nila because para hindi sila mahuli. So right now, hindi na lang siya, we cannot merely rely on the description on the drug. Pero dati, you just rely on the description. Pag sinabi nila, a pink pill, that's commonly as your LSD. Now, your marijuana, which is a cannabis or from your cannabis sativa or your hashish, which refers to a more potent product produced by the extraction of the resin from the plant. So this is the resin actually of your marijuana. So this is somehow the purest form of your marijuana. So the most active compound of your marijuana is your delta-9 tetrahydrocannabinol or your THC, which is a psychoactive agent. Metabolites, we have your delta-9 carboxy-THC, we have your 11-hydroxy-delta-9-THC, which can be detected in the urine 1 to 4 weeks after. So these are the metabolites now of your marijuana. Now we have your tryptamines. So sa tryptamines, meron tayong tatlong important compounds dyan. We have your serotonin-based, we have your psilocin, and your DIPT. So derived from your serotonin, your DMT, which is a rapid onset of a strong hallucinogen effects. Ito yung tinatawag nilang businessman's lunch. Then we have your psilocin, which is a component of your psilocybe called your magic mushroom. So this is the magic mushroom because of its hallucinogenic effect. And your I cannot pronounce it well, ayahuasca, which is a mixture of plant with your DMT and your carbolines from your South American tea. So can induce nausea and vomiting. So these are mga not so common drugs of abuse. And lastly, we have your piperazines. So your piperazines, basically your BZP or your A2, your N-benzyl piperazine, and your temp or your molly. Still, you have your euphoric effects and almost the same effects of your amphetamines. Again, these are not very common drugs na ginagamit. So, we have only a very short discussion right now. When you read your Bishop, it's only toxicology is only one chapter, and our topics in toxicology is subdivided into 4. So, masyadong maliit lang ating topics. That's why I want you to read your Bishop. Kasi nga, sobrang lit. It's only less than 5 pages yung drugs of abuse or 3 pages lang. So, please read the Bishop topics, specifically the drugs of abuse, and also in your clinical Henrys, because I will get some points directly from the books and the things that I discussed here. So basically, these are just basic concepts. I know somehow this is very technical kasi nga masyadong maraming mga drugs na mga terminologies, but I just want you to go back with the book. Read your Bishop and read your clinical Henrys because I will get certain points from those books, specifically from the topic ng drugs of abuse. And most importantly, sa aking mga diniscuss. These are very short topics lang naman. So that's it. If you have any question, please do not hesitate to ask me. Please PM me anytime. I will try to answer all of your questions as fast as I can. So that's it for this week. I hope that you will have a blessed Holy Week. Have some time to chill for the Holy Week. Have some time to reflect. This is the time to reflect, not to study. So please do not study, but somehow just try to reflect, chill, and God bless you, everyone. So God bless everyone, and thank you.